a brief background on this topic that I want to provide for you. So we have been talking a lot about safety and quality of neonatal oral feedings this year. And we've done some presentations on safety and quality at conferences. We've done a webinar at the National Association for Neonatal Therapists Conference. We presented this topic and talked about safety and quality, but we had these experts who also presented their stories. But we had the Q&A time at the end, and it was rather short. We had so many questions we didn't get to. So from that is what, produced the idea to do this panel. So we wanted to give these people, you all, more time to answer these questions and to be able to have our guests on for a longer period of time. So that's why we're here today. So for our brief presentations today, we'll be hearing from each speaker consecutively, followed by the panel. And rather than me introducing them separately and jumping back and forth, I'm going to introduce them all now, and then you'll hear their presentations. So take notes, write your questions down, and be prepared to ask away. So our first presentation is from Brianna Bommarito and April Blandford-Cushing. So Brianna is an occupational therapist, and Dr. April Blandford-Cushing is a physical therapist and a board-certified cardiopulmonary clinical specialist. They both work for My Michigan Health in Midland, Michigan. They assisted in the special care nursery opening in February of 2023, and they continue to build the program for rehab services within the nursery and for newborn care within their hospital. They will be discussing how the use of Dr. Brown's products provides safe, consistent feeding experiences. And they'll talk a little bit about their QI project. Kelly Gardner has been a nurse for 13 years, with her bedside experience being a level 3 to 4 neonatal ICUs. She became a nurse manager in December of 2019 of a level 2 NICU, which has since grown to a level 3. Kelly started exploring Q-based feeding while pursuing her graduate degrees and found the reasoning behind the change in practice very interesting. As a manager, the implementation of infant-driven feeding and a culture change around oral feedings became very important to her as she strived to deliver not only the best in-the-moment outcomes, but also build progress for improved long-term developmental outcomes. And I think you'll find her statistics on what the nurses report about safety very interesting. And then we will hear from Jennifer Hofherr. Jennifer has been an occupational therapist for over 30 years and a NIDCAP trainer since 2005. She currently lives in Columbus, Ohio with her husband and 3 children. She's the neonatal therapy program manager at Nationwide Children's Hospital, supporting therapy teams across 10 NICUs, and has a special interest in feeding development, parent engagement, and clinical assessment tool development. Jennifer heads the Developmental Steering Committee at her hospital, Neonatal Feeding Steering Committee, and the ICU Safe Sleep Committee. In her free time, she enjoys exercising and taking long walks while listening to her favorite podcast. And we can't wait to hear Jennifer talk about how using Dr. Brown's bottle systems eliminated the nipple wars that units commonly find and that we hear about so often. And then we will hear from Casey Lewis. Casey is a speech pathologist based in Dallas, Texas. She owns and operates TechScope, a mobile endoscopy company that serves numerous healthcare organizations in Texas. Casey's specialties include dysphagia across the lifetime, as well as neonatal care. More recently, Casey became a NICU mom herself in May of 2023, after experiencing a placental abruption. Casey's experience of transitioning from clinician to caregiver in a space in which she has built her career has strengthened her heart for advocacy, specifically in the fragile environment of the NICU. And she will be speaking about improving safety of quality of oral feeding from both her therapist perspective and also as a parent. So again, we're going to have each presenter speak for just a few minutes on how they improve safety and quality. And by the way, if you'd like to watch that webinar, so if after this you really want more information about safety and quality, including tips to improve safety and quality and specific steps, you can go to our website, the Dr. Brown's Medical website, and that webinar is posted there. So let's hear from our presenters.
So I'm April and this is Bree. We just started with a brand new special care nursery in 2023. It's a 4-bed nursery. Initially, they were projected to have about 60 infants in a calendar year. In our very first year, they had 100.
Can we pause that just for a minute?
Nursery.
Oh, there we go.
We
Thank
were
you.
seeking advice from our colleagues from multiple health systems. We were very fortunate to get the great advice to prepare ourselves and to look to Dr. Brown's to help us feed our infants. They made it so very simple for us. We sent them an email and they've really been with us ever since.
Yep. So we ended up doing a quality improvement project with Dr. Brown's. And with that, Dr. Brown's bottle system was the only bottles that we used within our nursery. And we noticed that there was improved consistency, better feeding efficiency, fewer physiological events during feeds. And so we looked further into that and we kind of did a survey with the feeding staff, specifically a lot of the nurses down there. And we asked what they thought was the cause for this improved quality and safety. A few of the things that they said were the consistency with the nipple flow rates with Dr. Brown's, the zero resistance technology, and then just the uniformity of education and terminology used within the staff.
And what we've really found, and we're still in the middle of our quality improvement project, but anecdotally, what's been quite important to us as therapists is that we really have changed the conversations that we're having about the feeding for our infants, because we've been able to improve the quality and we eliminate that variable of the nipple or the type of bottle that we're using. We're using now this very consistent product. Our conversations have switched very infant-centric instead of talking about the bottle. And so that way we've really been able to put that infant at the center of every single conversation.
Hello. So we implemented infant-driven feeding in our level 2 NICU at the time. We were a 12-bed unit. When I started looking into infant-driven feeding, I knew that it needed to be a team approach. So we took a multidisciplinary route to implementation. So I started with a team of my speech therapist, my occupational therapist, my educator, and some of my key nurses in the unit that were interested in infant-driven feeding and how it could help our unit as well and our patients. So we got that team together, formulated some ideas around it, wrote our policy, did a big launch to get everybody excited, and we had gradually talked about it throughout kind of 3 months ahead of time of launching to get staff psyched about it, and then staff did all of their education. And as the week we implemented, we kind of had different prizes and party kind of different things, decorations and reminders throughout the unit to get everybody excited. As we have grown over the last year and a half, well, I guess it's been 2 years now that since we've implemented infant-driven feeding, my nurses are very happy that we are using this method of feeding our patients now. They feel like they are safe with their feeds. The quality of the feeds are better. And with safety, it gives the nurses the tools to make sure that they are aware of what kind of stress signals that are maybe a lot more subtle than what they were used to in the past. They're not volume focused. They're focusing on the quality, looking at the patient's tone, how they're responding, as well as their vital signs and whatnot as well. But it makes them feel safer. I think the parents also have a better understanding of what we're looking for with feeds and why we don't want to stress the infant out so that we have positive outcomes. And as I said, my nurses that have go to different hospitals, traveled, help out some other facilities in town, are very, very thankful that we follow the infant-driven feeding model and protocol here at our unit, and definitely feel like it is much safer and better for our patients. All right, and now I'm going to show you a couple of slides from the results of some questionnaires that we did with our nurses prior to and after implementation of infant-driven feeding in our unit. So we had a questionnaire that asked them about their satisfaction with the feeding method prior to implementation. And as you can tell, majority of the people were not satisfied with their current feeding method. And post-implementation, we had 81%, almost 82% that agreed that they were strongly strongly agreed that they were satisfied with the infant-driven feeding method. Then there was a question about how they feel that they were respected as a healthcare team member in making feeding plan decisions. That's another good component of infant-driven feeding, is giving some nurses their autonomy back. So prior to implementation, 15% of the staff felt neutral or strongly disagreed that they were a respected member of the healthcare team in these decisions. And post-implementation, all the staff that completed the questionnaire agreed or strongly agreed that they felt that they were a respected member of the healthcare team. And then we did another questionnaire 18 months post-implementation, specifically asking about safety and quality. And our nurses felt that feeding practices, 96% of them felt that they were safer and agreeing or strongly agreeing. And then they also felt that they had less pressure to get the infant to finish that bottle during the feed. 87% agreed or strongly agreed with that response. And our feeding practices were consistent across providers. So that quality component being consistent, looking at your readiness scores as every nurse, doing the same thing. So there's not that kind of pushback back and forth between parents, as well as shifts on one shift can feed the baby better than the other. 78% agreed that consistency had improved across our providers, and that we were mostly consistent now. And then how they felt their input into the feeds when we round on their feeding plan regarding infant cues and behaviors, feeling that their input was valued, and 86% agreed or strongly agreed that their input was now valued when doing those multidisciplinary rounds with their team and talking about the feeding plan. So in summary, infant-driven feeding has increased our nurse satisfaction and feeling of respect. Their knowledge has increased on feeding premature infants. 96% of our nurses felt that it was a safer method for feeding our patients, and that it allowed for that consistency amongst caregivers, improving our quality of each feeding.
Hi, I'm Jennifer Hofherr. I'm the Neonatal Therapy Program Manager at Nationwide Children's Hospital in Columbus, Ohio. We are a 10-unit, 260-bed network of NICUs, and standardizing care amongst all our units is an ongoing challenge and an opportunity. Today, I'm going to share how we ended what we used to call the nipple wars in our unit for good using the Dr. Brown's products. In 2019, we established a multidisciplinary unit-wide feeding steering committee. We wanted to explore the opportunity to use evidence and improve the quality of our feedings, and also to empower our nursing staff to make good decisions about which nipples to use. We also wanted to enhance our identification of homegoing bottles and nipple systems that families would have an opportunity to use and validate that they would be helpful to them when they went home. So at that time, we had available to us the fairly new evidence about the nipple flow rates from Dr. Pados. And at the time, these were all of the disposable nipples that we had available. Staff were quite enlightened to see what the flow rates were, but more importantly, how inconsistent the flow was with the disposable nipples in contrast to the consistent and reliable flow rates of the Dr. Brown's products. With that, we were able to just eliminate the majority of those disposable nipples. We also made the Dr. Brown's nipples available on the units. It was no longer just being handed out by therapy. And we developed a process for helping the nurses assess proficiency and efficiency of the infant's feeding using Dr. Lau's data. And this really helped empower nurses to make good decisions about whether the babies needed a nipple change or not. At this time, most of the nurses will actually skip starting with the disposable and go straight to the Dr. Brown's Preemie or Ultra Preemie, because they've really come to appreciate how important the slower flow and the consistency is for the safety of the infant's feeding. So as a result of making these changes, we've significantly reduced the frequency of nipple changes. Like I said, the nurses now don't even think that this is an issue. I recently asked a group of newer nurses what they thought of the nipple wars, and they said, "What are you talking about? There's no nipple wars here." And I was really excited to hear that. And the nurses have really gained a lot of knowledge and understanding about how nipple flow rates impact feeding behavior and skill development. And they've also learned that when there is a challenge, that the nipple changes aren't usually the answer to that, and so they are able to elevate their questions and ask for a therapy assessment more frequently.
Hi everyone, my name is Casey Lewis. I am a speech pathologist, a certified neonatal therapist, a certified lactation counselor, and I became a NICU mom in May 2023 after experiencing a placental abruption at 34 weeks and 6 days. I remember my emergency C-section. They removed 12 cc of blood off of my baby's lungs, and I think once I saw that, I really processed the gravity and seriousness of the situation. We spent 23 days in the NICU, and as a result of that experience, my perspective on the profession and the NICU space has changed forever. This has always been a place of heart for me and passion. But now I think things are very clear, especially revolving around the importance of consistency and consistent care and quality care, safe care, and ultimately helping the caregivers or the parents be the center of the baby's story. Here I am at my baby's bedside. I was in a wheelchair, I believe, in this experience. Even looking back at this picture is emotional for me, and I'm still processing what happened to me, and I think I'm just learning that that's just how it will always be for me. My baby's on high levels of respiratory support in this picture, and at that time she wasn't appropriate to eat by mouth, but she was appropriate for skin-to-skin care. So I just completed skin-to-skin care prior to this image and put her back to sleep. Once she was able to start eating by mouth, she did utilize the Dr. Brown's products, specifically the Dr. Brown's Ultra Preemie nipple, and she stayed on that nipple whenever she got home, even for, I believe, at least a month, maybe 2 months. And this was because this flow rate was safest for her in terms of consistency, which is very important to me in terms of helping her learn to eat safely. She is one year old now, and she's still using the Dr. Brown's products, specifically the Dr. Brown's Level 1 nipple. She drinks from an open cup and from a straw, but we are still utilizing the bottle. I believe in this product. I believe in its safety and its efficacy. And it's important to help parents have a discharge plan and a feeding plan going home. And with the support of Dr. Brown's, we were able to do this for my little girl, and she is doing wonderfully. She has never had feeding difficulties, and I credit a lot of that to myself and my husband and the love that we've provided to her, but also the products that my baby girl was able to use. So thank you.
All right, we're going to have everyone come back on so we can ask some great questions. If you have a question for someone specifically, you can actually type in your questions like for Jennifer, for Casey. Otherwise, we will, I'll kind of, they might raise their hand, or I'll direct it to somebody I think it is. But we also had some people email some questions. So let's get started. Our first question is for Jennifer. Can you expand on how you got your unit to supply the Dr. Brown's bottles versus just being provided? This is a big question we get all the time. Versus just being provided by therapy. I've had some pushback on purchasing for the past few years and still advocating to get the bottles readily available. It's a two-part question. So hold that one, and then do you charge the patient for the bottles? So people want to know about how we stock these on the unit. And I'll let Jennifer answer, and then everybody has other ideas too. So let's just start with that question. I'll let Jennifer start.
All right, yes, good questions. And it took a little bit of time, but we worked with our products and value analysis committee, and they really did the work of looking at like what the cost differentials were and all of that. And that was clearly to the benefit of the reusable. And then we had to work with our infection control department, our Joint Commission readiness folks, and we met actually with Joint Commission to make sure, because we wanted to make sure we weren't going to get cited for anything. We actually have a very comprehensive policy and guideline to support all feeding supplies that we see, not just in the NICU, but throughout the whole pediatric hospital. Sippy cups and things that we use with older kids, so that, that we're following IFUs, and also if we're not able to follow an IFU, what the reasonable alternative is that the Joint Commission agreed with us on. So it was just working through all those different departments.
Great. Now, do any of you have any other tips about that as well, if your units stock them? Okay. And I also wanted to say that Erin Lesage, our director of sales, is here too. And she's jumping on as well if we have any other questions about specific hospital accounts, and she talks to, all the hospitals. So she's here as well to help answer questions. All right, this is another one, Jennifer, regarding nipple wars. Do you use just the Dr. Brown's? We're talking about nipples, but do you use just the Dr. Brown's nipples on hospital value feeds, or the entire Dr. Brown's bottle systems? And then a little bit more about cleaning, but.
Yeah, no, we use the whole system for sure. I also didn't answer the question about charging. We don't charge for the bottles. We actually have a whole charge capture system that anything over or under, I think it's $100, we don't charge. So, so yeah, we use the whole thing, and okay. Nurses clean and parents clean,
and I just wanted to add too. So the benefits of the bottle system and the benefits of the zero resistance bottle system. So that internal venting system, means that there is no negative pressure in the bottle. So it has a huge benefit, and actually removing that venting system can actually make the bottle, it does then affect the nipples as well. So you want to use the whole entire bottle system. It's meant to be used as a system. So.
And I was just
go ahead.
Little shout out to, we are here to help support. We've learned so much from teams like Jennifer's team that then can be helpful to a team that's starting the process. And we want to be that support for you. So your account manager can lead you to what documents can be most helpful given what we've heard from others. So please, please, please use us.
And my unit, when we implemented, to answer some of these questions too, we do not charge our patients for bottles either. We do 1 bottle per baby. As far as nipple changes, we put into our policy that nursing, unless it was for, a significant reason, such as more of the vital sign changes, choking, things like that with flow rates, that they are more than welcome to go down in flow. But the increase in flow rates should be evaluated by speech prior to going up. And that's kind of addressed our nipple wars and the inconsistencies, that nurses have the autonomy to go down if they feel like the baby is struggling. But as far as going up, to make sure that the speech is going to see them in the next phase.
Thank you, Kelly. You would mention how many bottles you supply. Anybody else give a reference for that as well? What do you guys do, Jonathan?
We also supply 1 bottle for each baby.
Kelly, what are somebody said, love your success. What are your tips for sustaining IDF?
So we, as onboarding, each new nurse does go through onboarding for it. Some of the biggest complaints from nurses is regarding around washing the bottles, because we do only supply 1. And so we have, our speech will also, an occupational therapist that feed our babies will also do part of the washing and cleaning there. We have volunteers in our units, and they are taught how to do that as well. So that's helped kind of with the struggle of feeding and getting to the next patient. We try to encourage parents to do that at the very beginning. Some are a little more reluctant than others. But as far as the sustainability, we talk about it in our NICU review every year as well. So just kind of going back to the basics of why it's important to continue to do. We look at compliance. My charge nurses do audits on a regular basis. So they look to make sure the nurses are charting their readiness scale and their quality scales, and caregiver techniques as well in their monthly audits that they do.
Thanks, Kelly. One more IDF question. What about your NEOs? How did you get them on board, or your providers in general?
So because our providers actually go to pretty much every facility in our town. So there's 4 or 5 different facilities that they go to, and every one of them does something different. We're lucky enough that most of our providers are consistent. So I have a leadership meeting with my providers every other month. So we talked about it beforehand. I had them watch the provider video. I also gave one provider access to watch the education as well, so that she could share her insights from the education with her colleagues. Our main provider medical director added a dot phrase into their progress notes. So they have dot phrases for that, as well as dot phrases for their feeding orders as well. So it follows the infant-driven feeding language on progressing there versus, PO every other, PO, those types of languages. So if we have providers that come that aren't typically here, the nurses do have to have kind of that conversation with, we go by this here. Can you change that order to match what we do in practice? The nurses pretty much are going to follow IDF regardless of what the order kind of says, but we try to make sure that order matches as well.
And obviously the best case scenario is for, anyone, everyone in the unit to be educated for IDF, and for the providers to take the course as well. I will say that when providers take the course, and conversations on rounds change, and that's how it leads the success of IDF, is how we're talking about these babies. We're all using the same language. And just a tip, if you're struggling with getting some of your NEOs on board, or the providers, is that the Vermont Oxford Network now talks about one of the, all care is brain care, and feeding is a component of that. So you can appeal to them, especially if you're a Von hospital. So just quick tip for getting them engaged as well. So there's a lot of questions about cleaning. We do have very specific cleaning guidelines that we can provide for you, but people have questions about the practical part of this. So, how are y'all cleaning the Dr. Browns in the hospitals? This is an issue in our NICU, so there's less interest in using them for all babies all the time. And, people want to know, do you clean in a nearby sink? That kind of thing. So who wants to describe their cleaning setup and how that works? And how, I think the question is, how do you make sure, people don't complain about the cleaning, but they see the value and say, yes, we have to clean them, but it's worth it. It's worth it, right?
Go ahead.
So we are fortunate in that we don't have to travel very far to clean our bottles. Every infant that has a Dr. Brown's bottle, they also have a brush and they also have a steamer bag. So we wash at the sink, soap and water after every feeding, and then they sterilize every 24-hour with a steamer bag. And then the nurses will chart that, in their feeding log, so to speak. One of the tips I suppose that I would give is, if you are having difficulty as a therapist with buy-in with your nurses, cleaning their bottles is some like magical, mystical thing for them. So that's a really great way to just get them to like you sometimes, is to clean all the extra bottles. And it honestly doesn't take that long. So we find it to be simple based on the smallness of our nursery for us to be able to clean. But I understand that if you're in a much larger center, that sometimes walking to the sink is more than just 5 steps.
I think also for the buy-in. So the end goal is to get these babies home with mom and dad safely. So if we're using the products that they're going to use at home while they're with us, the carryover, that transition can be flawless versus, all right, it might be easy. You don't have to wash bottles while they're with us, but then they're ready to discharge. Uh-oh, we got to transition to what they're going to use at home. So that helps us and our nurses huge.
Great point. Thank you. Thank you. What about Jennifer? Because you come with a much larger unit. So, what does that look like in a very large unit? I think sometimes the bigger units, we struggle with those.
Yeah. I think over time, people appreciated the function and the safety of the Dr. Brown products enough. And I think as we moved to that, it was the nurses making the decision to use those products, that, it just was part of the workflow. And so now it's just been around long enough that people aren't thinking like, oh, we have an option to not do this. It's what needs to be done. So parents and volunteers and everybody can do it. But yeah, we do the same thing. Everybody gets a package of brushes and steam bags, and every 24 hours we steam sterilize in the microwaves that are in various places, and it just gets done.
All right.
I do want to mention, it's nice to delegate duties in terms of sterilization. In my experience, it was done on night shift, and and then VAST were done during the day, to give that, make sure the parents are included, but you're also kind of dividing the duty among staff members. So that's a suggestion. If you're not already doing that, that has worked for me.
Thank you. April and Bree, you made a comment that your nurses, you say your nurses actually commented about the bottle systems and the zero resistance as well. How did you get them to understand zero resistance and not just the nipples?
A lot of education. We all, because of this nursery being new, they were so eager to hear whatever we had to say. So there's been a lot of trainings that we've had with them. And we're very fortunate that they're open to anything that we have to present to them. So I think for that education, helps with buy-in, helps with understanding. And then they can have those conversations if we're not there with parents and feel confident in what they're trying to explain to parents.
Yeah, again, thankfully, because of our size, I mean, we will be there. Doesn't matter which baby we're seeing, every nurse can hear what we're saying, and every parent can hear what we're saying, which is a plus and minus. So I do think, you know, we try to integrate them as much as we can, especially in the early days. Every word that we would say to the parents, the nurses were hearing, and then they were able to repeat those things. As you know, we talk about physics of, you know, we have a lot of very scientific parents around here. So we talk about physics of liquid and then, you know, timing and fatigue. And I think it's just kind of been their culture to always be around when we're around. So I think, again, like Jennifer had said, you just kind of get to the point where it's your culture and they know that this is the safest and most consistent product. And that's just what we're going to do.
I love that you're bringing in, obviously, educating parents from day one, but if, you know, you still need more information about zero resistance, reach out to your account manager. We do, you know, virtual site visits, but also we have some videos on our website that really do describe zero resistance. We have several articles that we can send you that we've written about zero resistance and the benefits of the Dr. Brown's bottle system. And it's not just about, I think one of them was called, it's not just about the nipples. So we can help you with that as well. All right. So we're talking about zero resistance and Dr. Brown's bottles and talking to parents about that. So one of the questions is about, sometimes we can't recommend specific bottles to parents. Like we've been told, we can't recommend a bottle system because we're biased. So what are your feelings about that? This is for Casey. What are your feelings about that as a parent and a professional?
I mean, as a professional and as a parent, because I think they coexist for me. I'm driven by science and I'm driven by data. And so I think you need to fill out the parent you're speaking to. And I've oftentimes provided data on flow rates to help provide a visual education to parents if that's what you feel like that parent is seeking. Now, some parents that might be overwhelming, but that I've utilized that in my own practice, and it's provided value for getting buy-in as to the why rather than selecting a specific product or brand. And, you know, at the end of the day, all hospitals utilize a multitude of different brands. Okay. And so don't let that fog your mind or your thoughts. Because there's multiple brands that are being recommended. And again, if you utilize the data, the Dr. Brown's provides the most consistent flow rate. And so if we're working with a fragile infant, that's what's most important. I hope that answered the question, but try not to let your mind or thoughts get fogged by branding, because that's not what is important.
I agree. And I'm gonna let Jennifer say that, because we do get that question sometimes and they'll say, well, we can't recommend that. It's like, well, they've chosen a specific diaper brand but Jennifer, can you want to expand on that?
Yeah, I think we came up with, I mean, this was kind of a hurdle initially too. And there was a lot of, just people weren't very informed about what the commercial costs were of Dr. Brown's. And there was a lot of people saying, oh, they're so expensive, our families can't afford it. And it's like, well, who are we to decide what they can afford and what they can't? But we were able to we have a handout of, you know, using Dr. Patos's information, you know, like here are all the various commercially available brands and, you know, what are the relative flow rates and price points. We just use like dollar signs, like you see like on the restaurant reviews, you know, so they can decide if they want to bring something else in. Then we say, great, bring those in, and we make sure that they are still safe and effective and efficient with those. But a lot of the families are already planning to use Dr. Brown's products. So there's a process for families to make choices. We're not forcing it on them, and most people were actually kind of surprised to learn that Dr. Brown's was one of the more affordable options.
Agree. Yes, it is. Thank you. Is there any research that anyone knows of that describes time to allow for adaptation to nipple flow before changing? So, you know, I think there was something in your PowerPoint, Jen, but frequent bottle nipple changes in the NICU has the potential to delay acquisition of feeding skills. And then I've also heard some presentations, people will say, well, keep the same nipple for 2 days. Or so someone wrote in asking about, is there research that talks about that?
Well, I don't know of any research, but
I'm not aware of any either, though. So, but still, people want to know, like, where are we getting this information, right? I mean, I go with consistency. We know that consistency is important, and there's research about, or articles at least, right, about consistency. The National Association of Neonatal Guidelines talks about we need to be consistent, and consistency is good for brain care. That's kind of where I go with that. But if anybody has any other information that they know for sure about that.
Yeah. I mean, if you're in a volume oriented system, then it appears that the nipple change to a higher flow works. But if you look at over time, the baby accommodates to that and ends up taking less. I mean, I don't know of any official research, but I mean, you see that anecdotally over and over again.
Yeah.
Where quality might not be any better, it actually can be worse. But
I think that changing a nipple based on certain days is kind of missing the point because of infant-driven feeding. And so every infant's going to be different in their story. For instance, my own baby stayed on the ultra-cream nipple for a very long time because consistent care is brain care. And that's what's important to her, because if I advanced too quickly, she was having difficulty. And I have no interest in that as a mom and as a clinician, but I also know in my own clinical knowledge and experience that increasing flow rate can actually prolong hospitalization. And I don't have data to provide you on that. I just have my own clinical experience and knowledge.
Yeah, thank you, Casey. Well, and we know that, you know, if you increase flow rate when a baby can't accept the increase in the flow rate, it does, you know, their respiratory abilities are not as good. And that's the problem is when people are doing nipple changes, they say success is because they took more. So, which we know is a volume driven, you know, component. So if we need to look at the quality of the feeding as well, right? Preaching to the choir here. So Jennifer, somebody did say, where can we go if we want more information about that process you were talking about for nipple changes? How can they get more information about that?
Well, first I'll refer you to Dr. Chantal Lau's work on proficiency and efficiency. This is where we used evidence to help say, like, we want to create a system where the nurses, if you really feel the baby needs a change, that we have data to support that as an assessment, a skilled assessment. So, and then I did do a poster for NANT in I think it was 2 years ago, that describes the assessment process. And if people want to email me, I'm happy to share that with them.
Thank you. So I'm going to bounce off a question back to Casey, to the ultra preemie. What advice do you have when you have neos who say baby can't go home on ultra preemie?
I mean, that's a complicated question. I think that every physician is an individual relationship that you're going to have to pursue individual buy-in and mutual respect and rapport. Babies can go home on whatever they're eating safely on and what their proven success record. I'm not sure where this thought process came from. I mean, I was even told when I was first starting in the NICU space that there's a certain, like the fastest nipple out there, they had to go home on that. And I remember, like, where is this coming from? Who made this up? And so I had to backtrack from just that nipple to just a little bit slower and a little bit slower and a little bit slower. And so that takes time. But I mean, it's almost like to me, I'm hearing like, well, the baby can't go home on this size diaper. You know, it's like, where does that knowledge come from? And so when you hear that, this person is certainly not understanding infant-driven feeding or what safe feeding looks like. And also I've utilized the diagnosis of pediatric feeding disorder and the implications on future health outcomes. Now, we certainly don't know if any of the infants will present with, you know, well, we could somewhat, but chronic feeding issues like at age 1 or age 2. But we're setting the foundation for success for that infant and for their families. And we know as feeding specialists that it's not just about how much the baby's eating, but future feeding milestones. And it's a very emotional process as a parent. There's mental implications, mental health implications as well. So I think utilizing, like looking up the pediatric feeding disorder diagnosis and framework to help guide that conversation could be useful.
Great information. Thank you, Casey. And I know sometimes providers want articles. I believe one of the Britt Patos's article actually has a statement in there that does say there is no evidence that a baby has to go home on a certain nipple. And so it does address it in there as well if they need an article for that. But and somebody asked about Jennifer about getting the poster. So when we email everyone afterwards with the eval link, we'll just provide that email for you. Advice in regards to babies that continue to show stress with even an ultra preemie flow. What do your hospitals do then? Do they consider a voluming limit or PO, holding PO? Who would like to address that?
I can. Clinically, if that's the case, and what I would do clinically in a general situation would be go back to pacifier dips or pacifier taste and backtracking your care. And I think what can be challenging is once we start initiating full oral intake, it can feel like as a clinician that we're backtracking, and maybe like we started eating with a bottle, we have to keep going. The baby is guiding the care. And so if the baby is indicating we're not quite ready, maybe we indicated some readiness yesterday, but maybe something's changed, you can change the plan of care, whatever is the baby's guiding the decisions. But I would go back to pacifier dips or nuzzling at the breast or nuzzling or dry breastfeeding at the breast. And so backtracking is important, and it's not bad. It's good to do that.
Agree. And I know that, sometimes we say to parents or, the message is, oh, baby isn't ready to feed. The baby can't do this. But like instead changing our language to talking about descriptions, what are the baby's cues? Well, the baby's really wide awake and isn't that great? So here's what we can do. And reminding staff that a negative experience, even if they're practicing, like a negative experience is not good. So every single experience should be positive, right? Not just occasionally a positive experience, but every single feeding experience should be positive. So, and focus on how can we make it positive.
I have one more thing to add. I often hear that pacifier dips or dry breastfeeding or nuzzling isn't oral intake when it is. The baby, you're putting a little bit in the baby's mouth to facilitate a swallow. And that is oral intake. And I've even had that conversation with providers to help them understand that counts. So please understand that.
Yeah. I think along the same lines, because I think people want, communication tools to use with their nursing staff. This question goes along with it. I recommended the ultra preemie slow flow. The nurse stood behind, there was no milk transfer in order to return back to disposable. How would you respond to that? Anybody have any good advice?
I mean, I would, if I wasn't present for that feeding, I would say, okay, well, let me reassess. Let me, what time, can I come back? Or obviously that's even if the baby's indicating readiness, but I would want to see with my own eyes. And maybe if that nurse is sitting with you, like, okay, that wasn't milk transfer from the nurse's perspective, but you saw something, maybe that's a one-to-one education moment, and also how you can build rapport and hopefully some kind of friendship out of that. So there's an opportunity there rather than to feel like that was a negative comment. It's really an opportunity to learn from each other and to build rapport and hopefully some kind of buy-in that that person could actually be an important guiding person for future initiatives with feeding. That's worked for me actually in the past.
Yeah, I agree. Sometimes if, one person says, well, they feed better on this nipple, they feed better on this nipple. I mean, feeding the baby together and having a conversation around feeding can be so beneficial. Let's look at it together and talk about it, right? Oh, go ahead.
That's okay. I was just actually having a conversation with Bree as we were waiting this morning about how we had a pair of twins and a nurse was feeding one twin right next to me. And it was kind of the first time that we had been in really close proximity with one another while she was feeding this other infant that was not necessarily having the best time about it. And despite all of the education that we provide about stress and they have identified readiness well, and she just wasn't picking up on a few things enough for me to say, let's just take a pause. The infant is demonstrating, X, Y, Z, and she had at that moment just kind of been focusing on something else. And she was just very open to, this is what I'm seeing. Why don't we try a different approach or take a pause? And just understanding sometimes that if an infant is demonstrating that they are responding well to that feed, even though their volume isn't successful, that's like a yay happy day for us, right? If they have a bottle in their mouth and they like it, despite the fact that there's no volume transfer and they are comfortable and, they're just showing you all of these good things and the volume is 1 milliliter, then yay for that 1 milliliter. And we have to reframe success all the time. And I think it just reminded me we had been doing this for so long now, but she just needed that little, it's okay. Just give them a moment and reintegrate the nursing staff sometimes as to what success really looks like.
I love that phrase, reframe success. Thank you. Yeah.
I have something to add about the parent perspective and discharge planning about getting the bottle, solidifying that plan. Certainly, I know I have the perspective of clinician in this space, but so often I feel like as clinicians, we worry about like what that feeding plan is going to look like for home, like with the nipple. We want to solidify that. That was the easy part for us, for me and my husband. What was the hard part was solidifying what the formula mixture was with breast milk and like how to make that at home rather than the feeding plan, because that was so well established in the NICU. And so oftentimes I find that is not even recognized, because in my experience, that conversation about what like the mixture of formula and breast milk, because I was providing breast milk at that time because she was on fortified nutrition, that was like more quickly given to us than the feeding plan. The feeding plan was so well established. And so I think that's a conversation to have within our NICU teams. Like, why aren't we discussing this and educating our families more on this? And it just seems kind of like for some reason, there's so much awareness about the feeding plan, and there should be, but sometimes there's an opportunity for improvement for other things as well. And so kind of, having other conversations. Yes, the feeding plan is important, but, and it's crucial, but that was my experience it was much harder other aspects of feeding were much harder because the nipple and everything was much more well established.
Thank you, Casey. That's a great perspective. All right, we have time for a couple more questions. I can't believe an hour is almost up. This is an IDF question. Where do I start if the goal is to hopefully implement IDF in our unit? So many pieces. What has been the successful starting point? Kelly, any advice about that?
So getting a team together that, is interested in this idea. And learning more about it. There's lots of information, different articles, as well as the website is very informative. So getting your team together with both nursing staff, speech, providers, making sure everybody is on the same page with going through with implementation. And then I will say, Erin was my account manager at that point in time, and they have tons of resources on this is an implementation plan, and I'm sure they've adapted it over the years as other hospitals have given feedback. And so there is a checklist to go through. They really have made a great process for implementation. You are going to need financial support depending on your learning module system and how your system operates, on whether it has to be integrated into your learning module system or not. Then the supplies, so your supply chain, making sure those supplies are available to you. So there is a long process. It does not happen overnight. It takes months to get ready. And then you've got to psych your staff up too. So having some champion nurses that are excited, that are sharing information on both shifts back and forth and just talking about some of the highlights. I was lucky enough at the time because the original education that my team did was around 5 to 6 hours of online information. And we were lucky enough to have a low census at that point in time. So we would split shifts. And so half the people that were scheduled would go and do education. They come back to the unit, switch off, and then the other half would go. So they were getting their hours, but we were getting that education done within like a 3-week period for about 65 staff members. We got all of that done, and then had a question and answer, a live session with both of our speech as well as myself and our educators with the team. So kind of a staff meeting with questions and answers, formulated that list of things and sent that out to everybody. So everybody got to see those questions and answers. And then we went live within the next week.
Thanks, Kelly. Yes, and as Kelly said, Dr. Brown's, our team is here every step of the way. You know, each territory has a specific account manager that we can connect you with, and that when we go through the whole process with you. So,
and some of the things, we also learned things along the way too. So staff always gave feedback in our monthly staff meetings and in huddles, or just sending feedback to me via email. One of the things that we did start doing, we have Epic and we use the sticky note process. And we now have a dot phrase that they put in. It's a standardized dot phrase that has that nipple. And when they're ready for readiness scoring, that type of thing in there. So that information is passed on from shift to shift. And if there are any changes, that's noted there as well. So they can kind of see the history of if speech changed the nipple and why, that kind of thing.
Thank you. We are out of time. I want to thank everyone for being here today, and thank you to all of our presenters and our panelists for discussing all of these complex questions, and just for being available. And I just also appreciate, Casey, your dual perspective and your vulnerability at being here. So I have a slide that I want to pull up real quickly on the other end. If you can pull that up for me, please. Thank you. I just wanted to mention that our guests have shown today that the Dr. Brown's model of feeding together, if we're all working together to provide those right feeding products and practices, can improve. I hope you've seen how that it can improve safety, consistency, and quality of feeding for infants and their families. So let us help you achieve that in your units. And if you want to get a hold of us, there is some information here on the next slide. That is our Dr. Brown's Medical. You can email us or you can go to our website. In addition, as I mentioned, our account managers are specific to territories.